Chapter 14, Comorbidity and Other Disorders. When we look at the various types of comorbidity and other disorders, we do have to take into consideration the ones that are not very common or we do not run across. However, our clients might um, exhibit symptoms from these disorders or have a diagnosis when coming in of these disorders. When we look at chronic pain, various types of medication that can be used to treat chronic pain are antidepressants. And when we look at antidepressants, specifically the tricyclics or the SNRIs. The tricyclics will lower, in a lower dose, can be used to treat chronic pain than when they are used to treat depression, which is usually a higher dose. In low doses, these medications can relieve nerve pain, but then unfortunately the tricyclics have the anticholinergic side effects, so the dry mouth, dry nose and throat, and as well as constipation. Whereas then the SNRIs aren't equally as effective without the anticholinergic side effects. So duloxetine, but with the trade name Cymbalta, has been effective. Milnazepam is also another one that might go by the name Savella, but this is to treat chronic pain. Is also used to quite often used to treat fibromyalgia, and it's becoming the new standard to treat chronic pain regardless if the client has depression or not. So this is another SNRI that has been effective with chronic pain. When we look at the calcium channel alpha ligands, we are looking at which is an anticonvulsant medication and is currently also used to relieve neuropathic pain. It is recommended as a first-line agent to treat neuropathic pain, so that is another option of medication for clients who are experiencing chronic pain. And then the final is topical lidocaine, which is pretty much so a topical numbing ointment that can be used on top of course, the skin, whether it's for scrapes, burns, eczema, or any kind of uncomfortable feeling that the client may experience. Now, as we look at eating disorders, we will see that also antidepressants can be used with the various types of eating disorders, and specifically when we look at anorexia nervosa, bulimia nervosa, or binge eating disorder. Now, with antidepressants, what we're looking at is for anorexia, an antidepressant may help if the client also has depression, anxiety disorder, or obsessive compulsive disorder. So that's where it might be beneficial once the client is, of course, especially if their weight has severely dropped and they're hospitalized, and once weight becomes stable and they become healthy, we might look at, well, from a physician stance, prescribing an antidepressant. For bulimia nervosa, this may reduce the frequency of binge purge episodes. So we have to look at it from that stance. That now the client might also have depression because this often occurs with bulimia. So besides the whole addressing the binge purge episodes that might be reduced from antidepressants, we also have to look at it. Even with, as mentioned, with anorexia, a client might have a comorbidity with the depression, anxiety, or other disorders. Binge eating with antidepressants, it targets brain chemicals that help control mood. So boosting a client's mood may help against binge. So antidepressants, once again, can be used with all three of the eating disorders. When we look at mood stabilizers, it's pretty much so the same as the antidepressants. And with the mood stabilizers, we're more so looking at what are some of the symptoms. So for like a binge eating disorder, if it's controlling, their mood, then we might want to, or if they are displaying depressive symptoms, that might be why a physician might actually prescribe a mood stabilizer, because oftentimes they are looking at the symptoms. When we're looking at a person with the eating disorder, there may be an underlying feeling of depression. So we might look at, besides antidepressants, mood stabilizers. However, overall, as a general practice, although there's some evidence for using mood stabilizers to treat eating disorders or clients with eating disorders, um, the mood stabilizers may have an adverse effect, such as weight loss. So, mood stabilizers are often not the first choice for eating disorders. So, that's just something that it's an option. It has been used, but it's not often used. And some mood stabilizers that have been used have been topiramate as well as lithium. Atypical antipsychotics are also medication that have been used to treat eating disorders. And in anorexia nervosa, certain antipsychotics such as Zyprexa, Risperdal were used to more so reduce the delusional thoughts about food, as opposed to the eating disorder itself. As well as, so, and for the most part, I'd say it's, if the antipsychotic was going to be used, it will be more so with a person with anorexia nervosa as opposed to the binge eating, and maybe perhaps with someone with bulimia, depending on, once again, what their symptoms are, and of course after a thorough assessment to get an idea of mentally their perception of, besides themselves, besides their body, the perception on food and just a variety of things. That will give you an idea if there are delusional thoughts, and perhaps, like I said, the right type of medication. Is there a depression? And to get a better idea on what medications might be beneficial. When we look at anti-obesity medications, there are prescription as well as over-the-counter medications such as an Orlistat and like a Xenical, which is a prescription, but an Ally, which you can find in the stores. And what this medication will do is it works to not allow the body to absorb fats from foods consumed, and it's pretty much so just passed right through. Now, unfortunately, some of the side effects are a person may have oily gas. The oils might leak through their rectum without them even knowing it, especially if they're eating the greasy, unhealthy foods. So, I mean, that's one of the side effects. But for the binge eating as well as for obesity, we do have medications such as the Orlistats. Finally, when we look at our last disorder, we look at impulse control disorders. So this is, various disorders like pathological gambling, kleptomania, pyromania, trichotillomania, intermittent explosive disorders, amongst other ones. And when we're looking at this, and I'm going to talk about the next slide, the types of therapy, but cognitive behavior strategies have generally shown evidence for the first line of treatment with a lot of these disorders. However, if we were going to treat it from a pharmacotherapy stance, certain things as certain antidepressants as I'm getting tongue-tied again, serotonergic antidepressants such as Luvox, fluoxetine, or Prozac could be used. Elavil. Some mood stabilizers such as lithium, so we're looking at Depakote, Topamax, have been successful in some case studies when we're looking at impulse control disorders. Opioid receptors, such as, of course, the naltrexone, we talked about that before, trade name Rivia, work great with impulse control disorders, resulting in positive outcomes, especially for pathological gamblers. We already talked about the SSRI, mood stabilizers are great. SSRIs have shown benefit as the first line, of course, of short-term treatment of body dysmorphic disorder. We look at atypical antipsychotics such as the Risperdal, the Zyprexa, have also had positive responses. And so, I mean, just overall, just depending on it, just with these impulse control disorders, we have to look at the symptoms to figure out exactly which one would probably be best for our clients. However, just looking at them all, you can see it is almost like a fruit cocktail of psychotropic medications that can be used for this disorder, as well as many other disorders. Finally, when we look at treatment, psychotherapy is always great for comorbidity and other disorders. What has been found to be most effective, not saying that any other psychotherapy would not be effective, but is the cognitive behavior therapy. In certain cases, like when we look at eating disorders, as well as chronic pain, cognitive therapy, um, sometimes along with medication, can be very effective. And briefly, just to not overlap, of course, other classes like your psychopathology classes and many other ones, but just to point out how with cognitive behavior therapy, when we're addressing these comorbidity and other disorders, I mean, the key is to help the client who's suffering from the chronic pain or the eating disorders or the impulse disorders, to understand the relationship between their thoughts, emotions, and the actions that they're doing, which is highly important. And as therapists, of course, our goal is to help our client understand how the negative thoughts and emotions have led to the abnormal behavior, whether it's the constant pain that they're feeling, or either that chronic pain or the eating disorder, their abnormal behavior when it comes to eating and their thought process when it comes to eating and in the behaviors that follow, or even those impulses that they're displaying under, the impulse disorder category. So along with what first line of defense would be cognitive behavior therapy, but if we see that that is not really beneficial or the client is not really moving forward in therapy, then we might look at adding a pharmacotherapy component to it.